In this chapter, we will discuss peripheral venous disease in neurosurgery patients. My name is Michael Zhang, and I speak on behalf of my team, Dr. Vikin Pamukian and Dr. Stephen Skirball of the Departments of Neurosurgery at Stanford Hospital and the Division of Vascular Surgery, Department of Surgery at Northwell Health. As an overview, peripheral venous disease management is designed to prevent progression to pulmonary embolism, where mortality rates range between 9 and 50%. Venous thromboembolisms are higher for spinal and cranial neurosurgical patients, where they measure 0.6 and 1.1% respectively. Management considerations, which we will review here, include an evaluation of the patient's risk factors and their involvement in special populations where treatment is trickier, as well as considerations for which diagnostic tools and follow-up tools are needed, prophylaxis and treatment regimen design, and outpatient and continued regimen design. For risk factors, classically they have been attributed to the Virchow triad of thrombosis, which include immobility, hypercoagulability, and endothelial damage, all which are very prominent in neurosurgical patients. Individual risk factors include history of prior venous thromboembolism, malignancy, sepsis, ventilator dependence, immobilization, elderly age, obesity, smoking, chronic steroid use, pregnancy, postpartum, estrogen therapy, and inherited thrombophilia. Neurosurgical specific risk factors include history of a cranial procedure, operative time greater than 4 hours, TIA stroke, seizures, and residual tumor. For cranial patients, these patients are particularly thrombogenic because of an upregulation of tissue factor and other coagulation cascade proteins. This is notably higher for higher grade gliomas, where the venous thromboembolism rates have been cited at 3.1%. A comparison across all cranial tumors have identified metastases, glioma, meningioma, and lymphoma with particularly elevated risks. Patients with subarachnoid hemorrhages are also known to have higher DVT rates of 18%. Patients who have had traumatic brain injury are cited to have 3 to 4-fold higher DVT rates compared to the non-TBI population. Among spinal patients, cervical spine procedures are consistently with decreased likelihood of venous thromboembolism relative to lumbar procedures, and venous thromboembolism rates are lower for elective procedures. For spinal trauma, deformity, and degenerative spine populations, DVT rates are higher at 19, 14, and 9% respectively within one study. The spinal cord injury population is a unique group where DVT rates are considerably higher. Based on one criteria where they measured radiofibrinogen, 100% of patients in a cohort were identified with DVTs. When diagnosing a patient, the clinical pretest probability is essential for moving forward with evaluation. This avoids unnecessary treatment because of the high false positive rates that exist. The neurosurgical patient is often with predisposing risk factors such as cancer, immobilization, prior surgery, that all put them at a moderate risk based on traditional scoring guides such as the Wells DVT score and the PE scores. Additionally, the Pulmonary Embolism Severity Index can be used to predict the risk of death within 30 days should they develop a PE. When considering the laboratory tests to be used for screening, D-dimers should not be used for post-surgical patients as they can remain elevated for several weeks. Antithrombin, protein C, and protein S deficiencies are unlikely to be revealing since levels decrease with their immediate consumption, but factor V Leiden and prothrombin gene mutations can be done at any time. When patients are being treated with heparin, there is also concern for heparin-induced thrombocytopenia, in which case workup should be guided by the 4T score and enzyme-linked immunoassays. Platelet monitoring should be done from the day of initial suspicion and trended. For diagnostic imaging, venous ultrasound is the mainstay for identifying DVTs of the upper and lower extremities, as they exhibit sensitivity and specificity rates of approximately 95%. Risk stratification is best achieved with whole-leg venous ultrasound, since isolated distal findings are with very low likelihoods of extending beyond the popliteal vein. If there is finding of an isolated distal event, a repeat lower extremity ultrasound can be performed at 7 days. If stable, the distal lower extremity DVT is again likely with low risk. Meanwhile, CT pulmonary angiography is the primary screening tool for pulmonary embolism, as PPV or positive predicted value rates reach 97% for the main or lobar pulmonary artery abnormalities. This decreases to 68% or 25 to 50% for smaller segmental and subsegmental thrombi. When designing a prophylactic regimen, all patients should get mechanical prophylaxis. Chemoprophylaxis is usually acceptable at 24 hours post-procedure. This is compared to a therapeutic dose which should be delayed for at least 72 hours. When selecting between unfractionated heparin and low molecular weight heparin, efficacy rates between these two have been comparable. However, specific nuanced differences exist for secondary outcomes for select populations. For example, among the spinal cord injury population, there has been comparable efficacy between the two agents, but low molecular weight heparin has exhibited fewer complications. When designing a systemic treatment plan, systemic anticoagulation should be considered in those with symptomatic PE or right ventricular strain on transthoracic echocardiogram. Full anticoagulation is said to be safe at 1 to 3 weeks, and a possible protocol begins with unfractionated heparin that targets a lower activated partial thromboplastin goal and avoids bolus administration. Systemic treatment plans should be considered on a case-by-case basis for those with identified submassive or moderate risk PEs, particularly if they are hemodynamically stable. This is because of the high false positive rate during workup. For those with such equivocal pulmonary imaging, one consideration is to re-evaluate them for lower extremity proximal occlusions, which would indicate higher risk. Inferior vena cava filters, or IVC filters, can be considered when trying to delay early anticoagulation among patients who are hemodynamically stable and with acute DVTs. Filters are not without risk and should be offered judiciously. Generally, they are not recommended for low-risk DVTs, such as isolated distal lower extremity DVTs, upper extremity DVTs, or chronic DVTs. One can consider repeating a lower extremity ultrasound a week following findings of an acute distal extremity DVT, as they may actually maintain their status and stay at a low risk and therefore not require a filter placement. Filters should be removed within 6 months of insertion. Upper extremity DVTs are still considered risks for PE, but less than those for their pelvic and lower extremity counterparts. If detected, upper extremity DVTs should still be treated with acute anticoagulation when possible. However, when not possible, and associated with a central line, direct line removal is still considered priority over IVC placement. When designing an outpatient regimen, risks for venous thromboembolism for post-surgical patients remain elevated for the first 12 weeks, and therefore anticoagulation is recommended for at least 3 months. More time is suggested when there is identification of an unprovoked DVT or symptomatic PE, at which point extending treatment is recommended for 6 to 12 months. When selecting an agent, certain studies have demonstrated higher efficacy rates of certain agents in certain populations. For example, there is a preference for low molecular weight heparin over vitamin K antagonists in cancer patients. When using a vitamin K antagonist, these typically have been targeted for an INR goal of 2 to 3. Finally, direct oral anticoagulants have become an important pharmaceutical option in the outpatient setting. Clinical trials for these agents have typically excluded the neurosurgical patient, making it hard to generalize findings. Overall, though, direct oral anticoagulants are more convenient in the outpatient setting given that they have predictable anticoagulation responses and can be done with fixed doses without the need for laboratory monitoring. In the event a patient on a direct oral anticoagulant presents with an acute bleed, it is important to know which tests can be used for specific agents. For dabigatran, thrombin clotting time and ECRIN clotting time tests are used. For direct 10A inhibitors, heparin chromogenic assays can be used. And it's also important to know that direct oral anticoagulants have short half-lives that can be adequately reversed in minutes. These agents have also been associated with IPHs, intraparenchymal hemorrhages, that are not necessarily with increased mortality risk or increased hematoma and expansion risk compared to typical vitamin K antagonist-associated intraparenchymal hemorrhages.